Hey guys, so in this video I am starting the Ortho part 2 and we are going to discuss about the pediatric hip disorders and first one is the Parthes disease. So let's talk about this one. So Parthes disease is leg, cow, Parthes disease also known as osteochondritis of head of femur. Osteochondritis of head of femur or cox and plana. So how do you exactly define this Parthes disease and what is the pathophysiology? So in this, what is actually happening? It is a avascular necrosis of the head of the femur, but the pathology is slightly different. So, osteonecrosis of head of femur, but this is idiopathic and spontaneous. And the reason being blockage of venous outflow. If the venous outflow is blocked, then obviously the vein will be thick and distended, and that's why it will cause arterial compression and this will lead to ischemia. So, thick and distended veins will cause arterial compression, so ischemia, and that's why osteonecrosis. So what will happen typically in an adult if there is a history of osteonecrosis of the head of the femur? The main pathophysiology will be arterial blockage by use of any steroid, or there is a trauma to the hip mainly leading to the fracture of the neck of the femur, so that's why the blood flow is injured. That's the reason mainly for osteonecrosis of the femur in the adult. In the adult it is mainly due to arterial blockage, while we are discussing the Parthes disease that is occurring in a child and in which the pathophysiology is not actually arterial. It is arterial blockage but indirect one. The main pathology is in the veins. So venous outflow is blocked, and that's why the veins are so distended that they are blocking the pathway of the artery, so arterial compression, and that is leading to the osteonecrosis. While in elderly, it is mainly due to arterial blockage directly, and the reason being is alcoholics, steroids, and radiation, or Gaucher's disease, sickle cell disease, and that will lead to this one, or it can be traumatic also, as we have discussed. Now, Parthes disease, if we see the epidemiology, it is more common in male child, and so the ratio is 5:1, so more common in male child than female child, and incidence in 1 in 10,000. You don't have to remember this. And most common cause is idiopathic, as we have discussed. We really don't know why the veins are getting blocked, but it is assumed that maybe it is protein C and S deficiency. So most common association here is protein C and S deficiency. So it is idiopathic. Okay. And bilateral is only 10 to 12% only. So how will the patient present to you? So the sign and symptom will be, so it is mainly will be a child, generally a male child, and here the in case it is a 7-year-old male child, for the last 2 weeks there is a history of pain in a hip radiating towards the groin, knee and thigh with tendency to deviate trunk towards one side. It will be limping gait or antalgic gait. Yeah. So we know that main feature will be the pain. Obviously, if necrosis of the head of femur is happening, main feature will be pain. So hip pain, and it will radiate toward the groin, knee and thigh, and this pain will lead to the limping gait, also known as antalgic gait. And then will be one sign will be positive, that is Catrell sign, that is obligatory excess external rotation during the hip flexion. So during the hip flexion, the leg will rotate externally. So external rotation will be there, and that is known as Catrell's sign. And child will, due to all this also, child couldn't sit cross leg and can't squat. Now in X-ray we can see there will be osteonecrosis, and we have seen the mechanism. And perthes is the most common cause of osteochondritis. In X-ray, you can see the crescent sign or coxa plana, means hip will be flat or plain, you can say. And gaze sign will be there. What is a gaze sign? V or U-shaped translucency in lateral aspect of head of femur. How are you going to manage? So it will be stage wise. Initial stages non-weight bearing or bed rest or skin traction mainly. and in later stage we will do total hip replacement. So in initial stage it will be like conservative, so non-weight bearing or bed rest, and you can give the broomstick cast, also known as patire cast. In later stage we have to do total hip replacement. So how are you exactly going to remember? And yes, MRI is the investigation of diagnosis. And if the disease is multifocal, we are going to do bone skin. So this was about the Parthes disease. So I am quickly revising this one. Parthes disease, osteochondritis of the head of the femur, मीन्स हेड ऑफ द फीमर का जो ऑस्टियोकॉन्ड्राइटिस होता है वो, ऑल्सो नोन एज कोक्सा लाना. And what is actually the pathophysiology that we are going to understand here, that Parthes disease is simply osteonecrosis of the head of the femur that is most commonly occurring in a child, and if it is in an adult it will mainly due to trauma or steroid, alcohol, sickle cell anemia, Gaucher disease, radiation. That's the reason. But in here there is a particular thing that in adults it is mainly due to directly arterial blockage, while here it will be due to venous blockage. And venous due to venous blockage the veins are so distracted that it is compressing the arteries, and that's why ischemia is occurring and osteonecrosis of the head of the femur, and it will lead to the osteochondritis of head of the femur as well as the plain hip joint. So hip joint will appear as a total flat. So this explains the name and the pathophysiology part and how will the patient present. So main complaint will be pain, and due to pain patient will present as a limping gait, and one sign we have to remember is a Catrell sign, that is obligatory external rotation during the hip flexion. And how we are going to diagnose? So MRI is the investigation of choice, but in X-ray, as we can see in the AVN, there will be a crescent sign, and also there will be coxa plana, means hip will appear flat. And one sign we have to remember is the gaze sign. So gaze sign is your U-shaped translucency that is seen in the lateral aspect of the head of the femur. And initially we can do the conservative management, so broomstick and Patrick cast, and in later stage we are going to do the total hip replacement. So here we have to remember Catrell sign, crescent sign, gaze sign, and broomstick or Patrick cast sign. So how exactly we are going to remember this name? So you can imagine a story that I have just now developed in my head. So crescent means you are imagining a moon. So there will be crescent, you are imagining a moon. So you are actually gazing the moon. And how are you actually gazing? So you remember in your childhood days there was a witch that is using this broomstick to like use as an aeroplane, like to fly in the sky. It was kind of an aeroplane of their own. And so in broomstick they are going to travel, and we we have to catrel. So catrel, what do you have in your mind when you are imagining a catrel? So you you are imagining a cat, right? So cat and rat. So you can imagine that one cat and rat is sitting here on a broomstick. Still Patrick. Patrick means okay, they are pets. Yes, they are pets. So Patrick cast. So you can remember this story, and by this I think you can remember Parthis. This is there is a crescent sign, gaze sign, and crescent sign, gaze sign. Also, we have to see the Patrick and broomstick cast and also catrel sign. Okay. So we are done with the Parthis disease finally. It was an easy one, if you say so. Now, what we are going to discuss is a slipped capital femoral epiphysis. So, slipped capital femoral epiphysis. So, it is actually a misnomer. Capital femoral epiphysis remains well seated in acetabulum, thereby maintaining an intact hip joint anatomy. It is at the onset of puberty that due to a rapid surge of growth hormone, what will happen? Physis disrupts laterally, giving rise to an apparent posteromedial epiphyseal slip, but in true sense there is no epiphyseal slip. So what is happening is, so we are first discussing the pathogenesis.